Okay, so we're going to move on to something a little bit different. My name is Huey Lin. I'm the director of the Adult Congenital Heart Program here and also adult congenital interventionalist. So most people, when they look at congenital heart disease, they think of this. They turn around and go running. These are my disclosures. And of course, there will be many off-label uses. So this is a 38-year-old tetralogy of Fallot. So if you don't know what that is, don't worry, I'll explain exactly what that is. In typical fashion, she'd had her initial surgery as a child, and then she had a second surgery to get pulmonic valve replacement. I'll explain exactly why that becomes the case. And at that time, she had a bioprosthetic pulmonic valve. The problem is she had a number 21. Typically, in a lot of these patients, we use a number 25 or number 27, but no smaller than that. Now at this point, she comes with suprasystemic RV pressure due to both valvular as well as pulmonary arterial stenoses. And I'll show you what that looks like in just a second. And at this point, she actually got referred to our transplant center for consideration of cardiac transplant because she had RV dysfunction as well due to all of these lesions. So what are we dealing with? So tetralogy of Fallot, for those of you who don't remember, and that's okay, is that the bottom line is this. You have an obstruction to the right ventricular outflow tract here due to the existence of muscle bundles that get worse over time. In addition, the pulmonic valve annulus is smaller than the aortic valve annulus. So it's here you can see it's about half the size. Sometimes it doesn't even exist at all. So the valve is extremely stenotic. So the first thing that the surgeon has to do is deal with that. And then finally, of course, there's a ventricoseptal defect. So that's tetralogy of Fallot in a nutshell. So what the surgeon has to do during that initial repair, and oftentimes we're doing it before 1 year of age these days, is that the surgeon has to remove those muscle bundles that obstruct the right ventricular outflow tract and then make a slice across the pulmonic valve annulus and then augment it by putting a big patch across that. And of course, you can imagine if you're going to slice across the pulmonic valve and then put a big patch across it, then ultimately you're going to leave the patient with pulmonic regurgitation. In fact, most of the time it's severe. So from the time of initial repair, all these patients have severe pulmonic regurgitation. So sooner or later, you're going to have to pay that piper, and they're going to need a valve replacement. And so that's exactly what happened to this lady, is in her early adulthood, she had a valve replacement. Unfortunately, she had a number 21 valve placed. I don't have a timer, so I guess I can go on forever. Okay, so this is a number 20. Now I got started. So this is a number 21 valve, okay? So the reality is a number 21 valve, even though it's rated for 21 millimeters, is in fact actually 19 millimeters internal diameter. And one of the really great things that's actually happened in our field is now the advent of transcatheter valve solutions, as you heard from Dr. Kleiman. And what that means then is if you already have this pre-existing pulmonic valve, this pre-existing bioprosthetic valve, you can just implant a new valve inside it when it becomes stenotic or regurgitant. Well, you can imagine what the problem is if you take a number 21 that has an internal diameter of 19. The strut thickness of the stent for the typical pulmonic, transcatheter pulmonic valve is going to be about 2 millimeters. So the next thing that happens is now you've got a 17 millimeter orifice. And this woman is about 100 kilos, so that's probably not going to work for her. So we can't just go in there and put a new transcatheter valve within the existing valve because you're going to have a Russian doll problem, and she's going to probably be worse than she was when she started. So this is what things look like in her, and that's why we can talk about just one case in this particular situation, because in this one case, we have all the lesions that we deal with in typical fashion and all the issues that we have to deal with advanced imaging. So what you see here is sort of a preview of what I'm gonna go into detail about, which is that we've taken the CT scan 3D reconstruction and merged it to her on-table fluoroscopy to guide the intervention and to understand exactly how this is going to work, and then find our way through each of the different vessels. The problem here is that her RV pressure is 100. A typical RV pressure is 30 millimeters of mercury. So she is near systemic RV hypertension. So she's very, very sick, and she needs to get all of these lesions fixed. So what does it actually look like? Well, so this is what it actually looks like when you look at the multiplanar reconstruction of the CT scan. And I won't go through that in detail, except to show you this basic understanding of what's going on here. So from the main PA, of course, she's got that, within the main PA, she's got that prosthetic pulmonic valve where she has one level of stenosis. But then going into both the right pulmonary artery as well as the left pulmonary artery, there are osteostenoses there in each branch as well. So we're going to be dealing with something pretty complicated, and the strategy is really of utmost importance. In typical transcatheter intervention, we go distal to proximal, right? That's usually how we do it, because if you stent something in the proximal section, you may not be able to get distally. So we needed to think about this flipped over on its head for a very important reason. I'll show you that in a second. So in typical coronary fashion, we would call this a Medina classification 111. Okay, so how do we get to the point of actually getting that image that I showed you where we have fusion? So instead of doing the 3D to 3D rotational angiography and co-registration, now what we can do is we can actually take two images in Cine in two different planes and then actually use that to do a complete co-registration of the 3D data set from the CT scan. So what are we doing? We're taking a CT scan pre-op that this patient has had. We're going to take the patient on the table under general anesthesia, prepped and draped, and then we're going to take a quick Cine loop from both one view and then a second view, typically LAO and then RAO. And then once we have that information, we have enough data there to go ahead and take the entire CT scan and then superimpose it to the patient's data on the table, just like you see here. And one of the really great benefits in this particular patient is that we actually have the bioprosthetic valve frame that is highly radio-opaque and serves as a perfect marker to allow us to co-register the data. And that's where we're going to be working, so the registration is going to be almost perfect. So once we have that, we have this. And this is going to guide us throughout the entire procedure. Now, sometimes it's a little bit cumbersome to have the entire 3D reconstruction superimposed on it. So what we actually do is we take regions of interest around the major stenotic segments to actually guide us for the intervention. So that's what this looks like. So what you see here is now we've registered the valve, but what we also see is the outline in red. That tiny little orifice is that stenotic RPA, okay? And what we're trying to do here is use a balloon flotation catheter to get out to the right pulmonary artery. You might ask, well, why would you use a balloon flotation catheter when we have these awesome robotic catheters to get there? Well, it turns out that when you go through the tricuspid valve is extremely fragile and extremely complicated. So what you want to do is you want to use a balloon flotation catheter to get through it to avoid entangling your future 16, 20, 22 French equipment in the tricuspid valve and tearing it up. So that's why you use a balloon flotation catheter to safely get through it, because once you get there once, you can put your wires through and safely navigate through it in the future. So you can see how that red region of interest really helped us to get out there without guessing as to where that RPA takes off. So our next strategy was, how are we going to deal with the valve? Well, it turns out that if you have a perimount bioprosthetic valve, you can actually crack the ring, and that's exactly what we did, because the restricting part is, of course, that plastic ring that the valve sits in. And so what we did was we chose a balloon that's 1 millimeter size larger than the rated ring size and went to high pressure, and then as we were inflating, we felt a click, and that was the breaking of the valve ring. So it's not a perfect solution. We only get about 2 or 3 millimeters expansion on it. So it's not like we've completely replaced the valve, but it does now allow us the opportunity to get to what she should at least have, which is about a 22, 23 millimeter orifice. We were hoping to get about 23, 24. So once we've done that, you can actually see right here, there's a little bit of a separation there. It's actually hard to see probably on this screen, but that is the fracture of the plastic ring. So once we did that, we took a Sapien 23 millimeter valve with rapid ventricular pacing and landed it right within the transcatheter valve. And when we measured our post-implantation diameter, we were able to achieve about 23 millimeters, which should hopefully get her through the next 5 to 7 years. Ultimately, she probably will need an open heart surgery to remove this entire mass, because we're probably not going to be able to expand this too much further. So why did we do proximal to distal? Well, this is why we did proximal to distal. So you can see when we now map the takeoff of the RPA, what would happen if we'd already implanted a stent in the RPA and then now took this gigantic delivery system for the Sapien? Well, for sure, the balloon would probably impinge on the stent. Well, when you have balloon versus stent, what happens? Well, I'm going to show you in just a second. And thankfully, we did it this way as opposed to the other way, because if we had balloon versus stent later on, we'd have a problem. So for sure, the delivery system for the Sapien is going to impinge on a possible stent in the RPA. For sure, the balloon from the Sapien system is going to impinge on the stent. So those are all potentially catastrophic problems that can make a very, very problematic case. So this is what it looks like, and you can see that the post-valve angio still mimics the 3D reconstruction very nicely, and the overlay works out very perfectly. Now, you might ask, well, okay, you've done this registration. What if somebody bumps the table, or somebody kicks the patient, or the patient moves? What do we do then? Well, the really nice thing about doing this 2D, 3D registration now is, instead of doing the rotational angiography and cone beam CT to re-register the patient, all you need to do is do 2 Cine loops again, and then immediately you can re-register your 2D to 3D data and then get an update on the registration. So This is what it looks like now as we set up to do our intervention. So we need to address both the LPA as well as the RPA. And one of the things we don't want to do is compromise the LPA when we stent the RPA. Our hope is that we can get away with just doing a balloon angioplasty of the LPA. So what we do is we do a balloon. As you can see here, it's very close to the sapien valve. And so again, I'm actually pretty glad that we did this proximal to distal. And then this is the RPA stent going in. And right at the end, you might see something. So we have a problem. Anybody notice what happened? The balloon popped, okay? So in this particular situation, the RPA was so narrow that we were able to engage the stenosis with the stent before the balloon punctured on the sapien valve stent and ruptured. Okay, so this is great. This is actually exactly what we want to have happen, as opposed to the other way around, where if we'd already put in the RPA stent, and then we're in the middle of implanting the sapien valve and pop that balloon, we would have embolized the sapien valve forward. And the worst possible situation is if the main PA is very large distal to the valve, then that valve could potentially tumble and become obstructive if it's moving in position. So this was easy to address. All we did was take a non-compliant balloon that's made out of a Kevlar-type material, and then that didn't puncture. We dilated the stent easily, and that was the end of our case. I guess I can let this play since I apparently have 6 minutes left. This is the end of my case, so I'm done. And so this is what things look like at the end, completely unobstructed flow. And actually, unfortunately, what I didn't show you was her RV gram before we started, but this is a normal RV now. She's completely decompressed her right ventricle, and this is exactly what we want to see when we see a happy right ventricle at the end of an intervention. And at this point, her gradient is really only about 10 millimeters going from the RV to her distal pulmonary artery. So things worked out very nicely, thankfully to the really great technology that we've been able to take advantage of with our collaboration with PonRoche. Thanks.